Welcome back to the Real Life Pharmacology podcast. Thanks again for all the support. The growth has been tremendous in the podcast, and that's simply due to you guys sharing with classmates, fellow healthcare professionals, and hopefully I continue to provide some good, relevant, useful real-world information. So today we're going to cover gabapentin and pregabalin. Now, these two drugs in clinical practice, they have very similar responses, clinical responses. As far as adverse effect profile, we'll talk about that. We'll talk about mechanism a little bit. Drug interactions, these drugs tend to not have a ton of drug interactions, so that's great. One thing up front I certainly did want to mention was cost. Gabapentin is much less expensive than pregabalin, at least at this time in 2018 here. As time goes on and hopefully pregabalin becomes generic, hopefully that cost will go down. But at this time, in most clinical situations, you are going to absolutely see gabapentin used first, and that's simply due to the cost factor there. But we'll talk a little bit about the kinetics and different things there too. So starting off on the mechanism of action, it's often thought, and you look at the name of the drugs, pregabalin and gabapentin, and you think about GABA is kind of initially what you think about. And I believe initially, don't quote me on this, but I believe initially it was thought that these drugs activate GABA receptors and kind of have a CNS depressant type effect through that mechanism. That is not the case. They do not bind GABA receptors, even though it's right in their name. Their primary mechanism of action is they impact voltage-gated calcium channels within the brain. And that can lead to a cascade of things. That cascade isn't incredibly well understood, but ultimately we can have some sedation. We can have some potential pain relief in various types of pain. Neuropathic pain is probably the most common indication you're going to see these medications used for. Any type of nerve pain, diabetic neuropathy. You will see it used for other types of pain where maybe we've tried other agents, they've failed, and they're not working. They are technically classified as anti-epileptic agents or anti-seizure medications. Within the use, as far as being a mainstay of therapy in managing seizures, they typically aren't. If you see a patient on these drugs, they are more than likely going to be used for pain. But it is important to keep in mind, in the odd chance that these drugs were being used for seizures, we have to recognize that missed doses and things like that could be incredibly, incredibly concerning if it would increase their seizure risk there. So just keep that in mind. Again, most often used for various types of pain syndromes. Now, as far as the side effect profile, I'm geared a little bit more towards polypharmacy, geriatrics, and these drugs can definitely cause some problems. Sedation is probably one of the biggest thing. I've definitely heard of people feeling totally zonked out. They feel like they could sleep all day, things of that nature. Dizziness, fall risk, that's definitely associated with these medications. Important to kind of remember and monitor that as a patient starts one of these meds and or increases. One other one that I definitely wanted to point out was edema, or swelling around the ankles, things like that. That can certainly be caused or contributed by gabapentin or pregabalin. So certainly keep an eye out for that as well. With the side effect profile, a lot of these side effects are always dose dependent. So the higher the dose you go, the more aggressive of a starting dose you take, you may see problems occur more quickly. And in my patient population, dealing with geriatrics primarily, so let's take a dose of gabapentin, 300 milligrams 3 times a day. That might be a little too much for a patient who's 85-year-old diabetic neuropathy or something like that. That may be a pretty aggressive starting dose. They may have risk of sedation, confusion, and things of that nature. So definitely be a little bit careful with that in our elderly patients. One other big important thing that I always look out for in patients that may be reporting sedation, dizziness, and they're on this type of medication is keep an eye on that kidney function. So these drugs are cleared by the kidney. So as that GFR, creatinine clearance, whatever measurement you're using, as that kidney function gets worse over time, which it generally does as people age, as that kidney function gets worse, that drug can accumulate and be more likely to cause side effects, even at a dose that they've been on for a really long time. So if we get a creatinine, we go from 1 to 1.5. Maybe a patient's been diagnosed with CKD. That dose that maybe was appropriate for gabapentin or pregabalin before is now causing adverse effects because the concentrations are higher, because the kidney isn't clearing it quite as quickly. One other really important point I wanted to make sure to be known, and this is on the pharmacokinetics side of things. So gabapentin has what's called a dose-dependent absorption model. And basically what that means is as you escalate doses, this drug requires a transporter to get across the gut. And as you saturate that transporter, that can lead to a reduction in the percent of the drug absorbed over time. So let's kind of clear this up and take an example here. So you've got a patient on gabapentin, 300 milligrams 3 times a day, maybe a younger patient, 30, 40, 50-year-old, for nerve pain, that type of thing, and we want to escalate the dose. And so we go from 300 to 600, maybe up to 900 milligrams 3 times a day. And when we do that, you may not get as big a bang for your buck as far as that percent absorption. So I don't have the numbers right in front of me, but let's just say you go from, at 300 milligrams, you go from 40% absorption, 600 milligrams, you go from 30 to down to 30% absorption. So you can see as a percentage, even though you went up 300 milligrams, you may actually get a lower percentage of that drug absorbed, and you may not see a very big kind of bang for your dosing buck as you increase the dose. It's not going to be a proportional increase in response, particularly when you get to higher doses with gabapentin. Now, pregabalin typically does avoid that. You're going to get pretty consistent absorption kind of all throughout the dosing spectrum from that medication because it does not require that transporter to get across the gut. So again, gabapentin at higher doses, when you increase that dose more, you may not see as great a bang for your buck in clinical response. So hopefully that kind of makes sense there. One other thing about both of these drugs is kind of controversial at this time, but there is a risk of dependence. There is a risk of drug diversion, and I have certainly seen theft with both pregabalin and gabapentin. Now, gabapentin, interestingly, from a United States federal level, is not considered a controlled substance. It's not classified as a medication that you need to keep track of and count. However, some states now are adopting this and putting it in their prescription drug monitoring program and all sorts of different stuff. So I would say there definitely is enough evidence out there saying that there is risk for dependence, is risk for diversion on these medications. So definitely keep that in mind if you feel like something is suspicious, something's not adding up right. Maybe a patient is continuously asking for way early refills, things of that nature. We do have to be a little bit of careful with that. Now, pregabalin is a controlled substance, a Schedule 4 controlled substance, I believe, maybe Schedule 5. Oh, sorry if I screwed that up, but it is a lower end of the schedule there. But it is under the Controlled Substances Act, and the DEA has classified that as a controlled substance. I suspect over time that gabapentin probably will be as well. So just keep that in mind, that there is maybe that risk of addiction, dependence, and things of that nature. Now, with these medications, I do have a couple of case studies within my book, Pharmacotherapy. And actually, I'm pretty excited about it. We just launched it on audible.com as well. So if you love listening to audio, if you've got a commute, it's a fantastic book with lots of pearls, case studies, really a good primer for any type of clinical rotation, residency, things of that nature for nurses, pharmacists, pharmacy students, and of course med students as well there. So again, Pharmacotherapy, you can check that out on audible.com. Also, we'll have a link at meded101.com/store. You can find a link to that Pharmacotherapy book as well there. So with that, one of the cases within that book, I talk about the weight gain issue with gabapentin and pregabalin, and that potential to contribute to swelling and edema. So as far as drug interactions go, there aren't a ton. I'll touch on one here coming up. But you do need to remember a couple of drug disease interactions. So in a patient with CHF, you're going to want to monitor any patient on these medications very closely to make sure we're not exacerbating CHF and that fluid status and edema and swelling, okay? So definitely keep an eye out for that. I mentioned the change in kidney function can alter concentrations, can raise concentrations of these medications, so you need to be aware of that if you've got somebody with an acute change. Now, as far as drug interactions go, I generally think of medications that have an additive effect. So any meds that may be sedating, for example, can kind of pile on and contribute to additive side effects. So opioids, benzodiazepines, antipsychotics, maybe first generation antihistamines like diphenhydramine, things like that. Any drug that can cause some CNS depression, CNS sedation, we need to look out for those when we're maybe adding and or increasing some of these other agents, and pay attention to our patients and really watch and follow those guys closely. With that, I think that about wraps up gabapentin and pregabalin. Check out reallifepharmacology.com. I've got that top 200 study guide, 31-page PDF, absolutely free to you for subscribing, following, and basically getting alerted to when we've got a new podcast out or new opportunities to look at there. So reallifepharmacology.com. Also, definitely if you wanted to take a peek at that pharmacotherapy book, you can find links to that on meded101.com/store. Thanks for listening. Hope you have a great rest of your day. And as always, leave us a review rating on iTunes. Greatly, greatly appreciated. We've had such a strong response to the podcast, and I'm hopeful I can keep up and try to provide you guys some good real-life clinical information. So take care. Have a great rest of your day.